Welcome. I'm Gina Vild. I'm the Associate Dean for Communications and External Relations at Harvard Medical School. And I want to welcome you all to our second Longwood Seminar of 2016, A Better Ending, A New Beginning for End of Life. Last week, we had 15,000 people join us from around the world in 27 countries through live streaming. We're live streaming again tonight, so to all of you who are here in the auditorium and for those of you who are joining us from afar, welcome, and thank you for being a part of our mini med school. I hope you can join us for the next two Longwood seminars, April 5th, Taking It All In, Environmental Toxins in Your Health, and on April 19th, the fourth and final seminar, The New Old Age, How the Body Ages and How to Keep It Young. Please review the screen behind me for announcements. Good. The question and answer period we feel is particularly important tonight, and so we are abbreviating our presentations just a bit so that we can really engage in a conversation with all of you. So we encourage you to write down your questions, and we will have members of our staff walking up and down the aisle, and please pass your questions because we really are hoping to have a very engaging conversation. So now for tonight's seminar, A Better Ending, A New Beginning for End of Life. George Bernard Shaw once said, "The single biggest problem in communication is the illusion that it's taken place." So tonight we'll look at the topic of dying from the perspective of communication and, importantly, miscommunication. Here at Harvard Medical School, we are committed to, in fact, we're responsible for, the science behind some of the most remarkable advances in the diagnosis and treatment of disease. Advances in medicine and public health have nearly doubled the life expectancy since 1900, doubled the life expectancy. But while these advances have extended our life, they come with some challenges. They've changed the very way that we die. Oftentimes, they make death longer and far more complicated. And tonight, what we want to talk about is this. Is that what we really want? Tonight's presenters are leaders in a growing movement that is bridging the best clinical care with the values of patients and their families through better communication at the end of life. They're bringing to the forefront of modern medicine a much-needed discussion about what it means to live and die, and how to do it on our own terms, with compassion and with dignity. Tonight, I'm honored to welcome three experts from Harvard Medical School's faculty, and they'll begin a conversation that we hope is just the start, that you'll leave this auditorium and you will continue this conversation with your family and your caregivers. Muriel Gillick is a Harvard Medical School professor of population medicine and director of the program in aging at the Harvard Pilgrim Healthcare Institute. She also serves on the medical staff of Brigham and Women's Hospital. Angelo Villanis is an assistant professor of medicine at Harvard Medical School and a faculty member of the Department of Medicine at Massachusetts General Hospital. But first you'll hear from Lachlan Farrow. Dr. Farrow is an associate professor of medicine at HMS and director of the ethics program and palliative care program at Beth Israel Deaconess Medical Center. He earned his MD from the Harvard Medical School. Dr. Farrow served as the chair of the Massachusetts Expert Panel on End-of-Life Care and was the lead author on its landmark report, Patient-Centered Care and Human Mortality. He has lectured and published numerous articles, books, and chapters on issues in medical ethics education, palliative care, medical decision-making, and the social responsibility of physicians. I leave you with this quote: "Much happiness has come to the world because of bewilderment and things left unsaid." Please welcome Dr. Farrow, and thank you.
Thank you, Gina, and thank all of you for coming and joining us in person, and the maybe thousands of people around the world who are watching this live video stream. I'm in my introductory remarks just going to try to help frame the issue, but I'll tell you what the single most important point from the evening is. As proud as I am of colleagues like Dr. Gillick, Dr. Volandes, many, many others, doctors, actually nurses, other people at Harvard and elsewhere who are working on this, the real wisdom we need And the real solution, the energy we need, is not actually the three of us. It's the 400 or 450 of you and the thousands watching and others are really where the solution to today's shortcomings needs to come from. Care up through the end of life has changed dramatically even since I was a medical student. When I think back, being a medical student here at Harvard, proud of all the exciting things that we already were doing, that I was learning about, even since then, things have advanced in ways that are breathtaking. Patients that I saw as a medical student with untreatable heart problems are now routinely treated, sometimes with surgery, sometimes with medications, other things, and live for years. When I was a medical student, they were going to die soon. Patients with cancer today, even though the death rates from cancer have not yet started to go down, patients with cancer today, almost every week, from Harvard or Johns Hopkins or other places, I read in the paper of, if not miracle cures, new medications with less side effects that can extend life in ways I never imagined. Maybe most dramatically for me, when I was a medical student, there was this new disease nobody understood, 4-H syndrome or something. There was horrible infectious diseases striking people with hemophilia, homosexuals, Haitians, others, that now we know as AIDS. And during my residency, there was nothing we could do. And then we learned, well, there's some infections that bacteria cause that we can treat with antibiotics, but it was a fatal illness soon. It was a death sentence. And today, thanks to work, Harvard Medical School, but actually throughout the world, AIDS is a almost always fully treatable condition. For a lot of people, it's a chronic disease. Patients with strokes. When I was a medical student, there was nothing we could do for someone with a stroke. We hope they survived. Maybe we could get them to rehab. There have been improvements in treatments. Some of you may have seen one of the earlier Longwood seminars about music and healing and the ways music can help people with strokes. But actually, when somebody comes into our emergency department with a stroke today, we rush with anticoagulant and other drugs that break the clot up. Sometimes we put a catheter in that removes the clot. The brain is saved. The person may not even have damage afterwards. It is mind-boggling and exciting, the biological, technical advances in medicine. But one thing hasn't changed at all. It was actually The Onion, a satirical magazine some of you know, had the headline about this. Mortality rate remains steady at 100%. There is nothing even on the horizon that will change the fact that for every single person in this room, every person watching, no matter what medicine can do, we're mortal. And yet we know that our health system, so energized, and not just by doctors, by all of you coming to us, pleading as taxpayers, funding NIH, we need miracle cures. They may change the time of death, but they don't change the fact that every single one of us is mortal. And in fact, in all of medicine, maybe even in all of life, for every one of you sitting here, everyone watching, this is the one issue that affects every single one of us and every person we care about. Well, maybe childbirth, but most of us didn't plan that in the same kind of way. We all know today, sitting here, me standing here, that myself and everyone I care about, everyone I love, one day will approach the end of life. Because of the exciting advances in medicine, when death may loom or an illness that might be fatal approaches, we plead, we scream, we search. Isn't there something that can cure this, that can fix this? The best that ever happens is it buys us a little more time. But we know with certainty that sooner or later the last chapter of our life is going to come. And when we stay in that medical, live as long as possible mode, what that last chapter is like is often not what any of us would want for ourselves or our loved ones. It is a really hard topic for human beings to address. Death has always been hard in every culture throughout the world. There's been a taboo on talking about it in every culture throughout the world. But cultures got along with that. They had rituals and other things like that. The danger, the problem for us today is that as death may approach, now we do things to people. We do things to people we care about. We even plead for doctors to do things to people we care about that are trying to deny what is an absolutely unchangeable fact. That in fact, we are all mortal, and in this last phase of life, there actually are opportunities, especially when time is short and precious, maybe not to be spending time thinking about the hospital, the machines, and all of those things, but maybe to focus on the things that are truly most important to us about life. You're going to hear from Dr. Gillick, who's devoted her life to caring for older people. I think a plea to think about this topic not as about dying just the very end, but actually much earlier than that, realizing that we're all mortal, and in knowing that we may be entering the latter phases of life, every day, every week, every month is precious. When I'm called in the hospital, my work as a doctor now is all inpatient, what's called palliative care. When called as a doctor, and I see a patient or see their family, and I say, do you know what palliative care is? How many people here would say you know what palliative care is? Right. I'm not going to ask you, or quiz you, because actually those words, palliative care, one of the first things that doctors now, nurses working in palliative care say, well, it's not hospice, it's different from hospice. Actually, when it was first coined as a term by Dr. Balfour Mount in Canada, he was using that for what Dame Cicely Saunders in England had started doing that she called hospice. So actually, initially, palliative care meant hospice. But it's really evolved because people have realized we have to start earlier and sooner. So when I'm with the patient, I say, well, let me tell you what palliative care means here at Beth Israel Deaconess. And I get to do that because I'm in charge. Right? Then they laugh. I said, when we're involved, palliative care to try to help you, it's always for a patient with a serious illness. It might be a serious illness that we're trying to cure. It might be a serious illness we know we can't cure, but it's always a serious illness. And then what I and my team do, we're consultants, we're supporting, is we are going to help you, your family, and your doctors succeed in two things. And I mean succeed. Number one, we're going to make sure you are always being taken care of the way you would want. Always. And there are lots of choices in medicine today. Some people say what I want is keep me alive as long as you possibly can. I don't care how many machines, I don't care how much suffering. That's not many people. But some people, that's what they want. We would never do anything inhumane, but we can get close to that. Other people are the opposite. They say, doctor, I've lived a good life. Please don't do any of those things. I just want, if I had one day at home with family. Most people are in between. But we're going to take care of you the way you would want. Number two, really the specialty of palliative care is whatever that plan is, we are going to make sure every single day is as good as is medically and humanly possible from your perspective. I don't care whether they're years of days or a few days. Medicine sometimes takes over the surgery, the other things we're proud of, and it squeezes out the humanity. That's backwards. You, the person, you, the human being, or your mom as a person, that's all that matters. All the medical things that I was saying I am so excited about, they're just tools. They make sense in terms of whether they're helping you as a person have the time that you have as a mortal person on this earth, have that be as good as it can be from your perspective. And then they're happy with that. Taking care of the way I want, every day as good as possible, and then I pause and say, but there's one other thing I need to say that has to be on the table. We are Americans. Some people watching are not Americans, but in the audience, we're Americans. We don't like to talk about that, and that is that every single one of us is mortal. That doesn't mean, that's got to be on the table, that doesn't mean anything about the plan. Some people, when I'm reminded that I or mom is mortal, it just makes me want even more, the most number of days I can have. That's okay. Some people reminded that my time's going to come sometime, suddenly say, you know, I just want to have as much time at home as possible. But when the fact that we're mortal is not on the table, we sometimes make bad choices. And then families look back and they don't say what every single person in this audience should be able to say when you lose someone, is that you ought to be able to look back and say, the last chapter, that last time, Mom was always taking care of the way she wanted, and the last part of her life was as full of love, joy, caring as it possibly could be. So we have work to do. I'm going to stop in just a minute because we're going to save time for your questions and thoughts. I want you to be thinking about not just questions for us, but ideas of what you can do. We're not going to get into money, but vast amounts of money. Some people say 25% of all US healthcare spending goes to the last 12 months of life. There's enough money to do this right, but only if you all figure out what you want from the healthcare system. I'm going to show you a video now of one patient where there are lots of medical problems, but asking the question about a good day changed everything about her care. Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with the patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. I was asked to see Thelma Patello. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, which she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess, most strikingly was that Dr. Farrow asked her, what would be a good day for you?
And so I sat down on the bed. I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question. What would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you? Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and I said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue,
I see skies of blue,
clouds of white,
clouds of white,
the bright,
the
blessed
bright,
days,
blessed
blessed
sun, and the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Pop, 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 pop. Oh, yeah.
And it made such a huge difference every day.
The music was right there as vividly as it had ever been. And every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and a kind of human joy returning. So our next speaker is Dr. Muriel Gillick. Gina gave you a brief introduction, and in the materials that are online, you can see her full biography. What I'll say about Muriel, I've known Muriel for a long time. In addition to, and I'd say more importantly than, the wonderful books and articles, policy and other kind of work that she's done, is that as a clinician, as an educator, including a number of years she spent working in our hospital as a consultant, patients, families, doctors, confronting some of these issues, struggling, when Muriel would come by with a combination of technical knowledge, you have to know how to manage pain and symptoms and those things, but just common sense and sitting with the humanity, the care that patients and families received, everybody, this is the way it should be. And then the policy and other work that she's done has grown out of that, so I look forward to joining you now and hearing some reflections from Dr. Gillick.
Thank you, Lachlan, and good evening. Or I guess for people in other time zones, good afternoon, good morning, whatever it is. So I know that many of you have come tonight to hear about end-of-life care, and that for many of you that means dying. But I have to tell you, as perhaps Lachlan hinted, I'm not really going to talk about dying. There have been lots of good books that have been written about dying. There have been lots of interesting projects that people have come up with to help you have conversations about dying, and that's all very, very important. But to me, life is a journey, and the part that I want to talk with you about tonight is the last stage of that journey. And that stage can last hours or weeks or days or months, but it can also last years. Yes, we all would like to believe that if only we exercise and we eat properly and we lead virtuous and upright lives, that we will live to be 100 and die peacefully in our sleep. And sometimes we have an end-of-life course that looks like the slide at the top, where we're fine, we're fine, we're fine, we're fine, and then suddenly something bad happens, and then we're not so fine. But more often than not, in this era, at least in the Western world where we are afflicted with chronic diseases, the last phase of life looks like one of these other two curves. For people who have heart disease or lung disease, it often looks like this. We have a gradual downward slope, and every so often we have a real blip, and when we're at the bottom of a blip, things don't look so good, but we may well recover and improve, though not usually to quite where we were before. And eventually, at some point, which may be, as I said, years later, we find ourselves at the bottom of a blip and we don't rally. Then there are other people who have typically a chronic neurologic condition, a progressive neurologic condition like Lou Gehrig's disease or Alzheimer's disease, who have a course that looks more like this, what I call in very scientific terms the dwindles. It's also the course that people who have what we in geriatrics call frailty have. Frailty is this sort of nebulous syndrome where typically people don't have just one thing wrong with them. They have lots of different things wrong with them. And no one thing alone would get them into terribly much trouble, but the combination conspire to make them vulnerable to having lots of problems. So what I want to do now is to tell you a story. I'm going to tell you a story about a patient I took care of named Sam Schaefer. He was a real patient, although that's not his name. And I wrote about him actually in my very first book with the not terribly revealing title of Choosing Medical Care in Old Age, but the somewhat more revealing title of What Kind, How Much, When to Stop. Sam, at the beginning of my story, was 83, and he wasn't in terribly good health, but neither was he in terribly bad health. And he certainly was not dying. He had a whole slew of medical problems. He had the usual, I'm afraid, in America when people are in their 80s. He had heart failure, and he had diabetes, and he had high blood pressure, and he had high cholesterol, and he had arthritis. And he took a whole bunch of medications for those problems. On good days, I would say he took about 9 medications. And on not so good days, when he had maybe chest pain or shortness of breath, he took 15 medications. He spent a lot of time monitoring his health. He was supposed to prick his finger to check his blood sugar. He was supposed to weigh himself to make sure he wasn't filling up with fluid. He was supposed to keep records of all kinds of things and bring notes to his doctor. Sam liked to take a nap every day, so he figured that between the time he spent sleeping and the time he spent taking medicines and the time he spent monitoring his health, and then a few other things like getting dressed in the morning, he had maybe 9 hours left in the day. But they were good hours. They were hours that he spent reading the newspaper. He was a real news maverick. There were times he spent going to concerts, and above all, there was the time that he spent with his great-grandchildren. He also went to what I believe these days is now called a Romeo Club, retired older men eating out. So he had a good life. But in the summer after he turned 83, Sam found that he was beginning to get tired a lot of the time. He didn't have the energy for the Romeo Club anymore. He saw his great-grandchildren less often because just watching them made him exhausted. And then before Thanksgiving, Sam got pneumonia. It started innocently enough with a little cough. It blossomed. He had a rip-roaring fever. He started to get confused. He ended up being hospitalized. Sam Schaefer was sliding into frailty. He spent a week in the hospital being pumped full of antibiotics, and then he was sent home a little weaker than before he went in, but managing. Pneumonia came again in January and in February, and each time he went to the hospital, and each time he went home and was a little bit weaker. And then in March, kind of out of the blue, he had an episode where he threw out blood, and he was rushed to the hospital again. And this time they found that he had a bleeding ulcer, probably triggered by one of the medicines he was taking for arthritis. But while he was there, he mentioned all the fatigue he'd had, and they actually didn't think that that could possibly be causing his ulcer, so they did all kinds of tests. And lo and behold, one of the tests turned up a brand new problem, which was that he had a narrowing of one of his heart valves. And that this led to a bunch of consultations, and the doctors told him he had 3 choices. He could be treated with medication, he could be treated with a moderately invasive or moderately not so invasive, depending on your perspective, procedure that would try to open up his narrowed valve, or he could have open heart surgery and get a brand new valve. And the doctors persuaded him that that latter was really the only viable option, the only good option, so Sam went along with it. And 2 months later, after his ulcer had healed up, he was readmitted to the hospital for open heart surgery to get a new valve. And he went through the procedure with flying colors. Most people do go through operations with flying colors. The problems began afterwards. He had one complication after another. He ended up spending weeks on a ventilator, a tube inserted through the mouth down into his lungs, attached to a breathing machine to help him breathe. He had infections. He had all kinds of complications. But he pulled through, and eventually he was well enough to be discharged, but not well enough to go home. So he went to rehab. And he was in rehab for several weeks. But even after the best efforts of physical therapists and occupational therapists and good medical care, he really wasn't able to make it at home. He couldn't get out of bed without someone helping him, couldn't make it to the bathroom without someone helping him. He certainly couldn't imagine preparing breakfast or lunch for himself. So Sam was discharged to a nursing home where he spent the next and last year of his life. So I've spent all this time telling you about Sam because most of this time, Sam was not dying. For at least the first 2 years of this story, he was not dying. But he was in the last phase of his life. And as such, there were choices that Sam needed to make. Those choices are very similar to the kinds of choices that people who are closer to the end of life need to make. And I would submit that they are not so much related to which medical procedure he would have, although that's exactly what his doctors talked to him about. The choices that he had to make had to do with his personal goals, what was important to him. Now, everybody has goals. You might want to live to be 90. You might want to go to Paris. You might want to see the birth of a great-grandchild. I once had a patient who said she was waiting for the birth of a great-grandchild, and I said, "Oh, is it your first great-grandchild?" And she said, "Oh, no, it's my 10th. So there are lots of goals that people might have. But from my perspective as a physician, there are really three major medical goals. There's living as long as possible, no matter what, as Dr. Farrow referred to some people wanting. There is living as actively as possible, walking and talking and hearing and seeing and singing and whatever else it is that gives meaning to life. And there's living as comfortably as possible, with as little pain, both physical and emotional. And of course, the truth is that we all want all three. Why wouldn't we? We want to live as long as possible, and while we're alive on this planet, we want to walk and talk and sing and dance, and we don't want to hurt too much while we're doing all those things. But the problem is that sometimes, not always, but sometimes, we need to make trade-offs. So what I want to talk with you about tonight, what I want to leave you with tonight, is that when you enter the last phase of life, or someone that you love enters that phase of life, or if you're a nurse or a doctor, somebody you're taking care of enters that phase of life, that the single most important thing is to try to figure out, as best you can, what really matters. And I say this because the way things happened for Sam, the way things unfolded for him, isn't really the way things had to unfold. If only Sam had talked to his physician, preferably with his daughter, who was his healthcare proxy, by his side, way back when, in the fall, maybe around the time of that first bout of pneumonia, if he had talked about what mattered most to him, I think that Sam would have said that of course he wanted to live as long as possible. Of course he wanted to see his great-grandson graduate from high school, even though his great-grandson was only 10 at the time. He wanted to see his great-grandson graduate from college and get married, but not if he was on such potent medication or he had progressive dementia, so he didn't even know his great-grandson's name anymore. That wasn't what was important to Sam. And I think if Sam's doctor had understood what mattered to Sam, then maybe he wouldn't have sent him back to the hospital so many times in that fateful fall when Sam was sliding into frailty. He might have treated that pneumonia at home, those pneumonias at home, which we can do quite nicely in many cases with pills and oxygen and a visiting nurse coming to the house. And he would have suggested, when that heart valve narrowing diagnosis was made, a medical rather than a surgical option. And if that had been what had happened, then Sam Schaefer just might have spent his last days at home and died in his bed rather than in a nursing home. So I began by saying that what matters to me is life's journey, and my particular interest is that whole last phase of life, which, as with someone like Sam, can last for several years. And what I do with my patients and what I've done in my writing and what I hope to encourage you to do is to think at each stage of the game, what matters to you, translating it into some of those medical terms for purposes of thinking about planning for health care. Think about what matters to you, and those things may change over the course of time as your situation changes. I left out, I wanted to make the point that not everybody shares Sam's view of living long, but living in a way that made sense to him. That there are some people who have lost so many things that all that matters to them is to be comfortable. And there are other people who want to live as long as possible, no matter what, though I have to say that some of them are denying a little bit the realities of their situation. But what I was on the verge of saying before is that you should think about what matters most to you, and that is likely to change as your situation changes. And so here we have a man, I'll say it's a patient talking to his doctor, and the patient announces, that is positively my final decision, unless, of course, I change my mind. And it is to be expected that you will change your mind as your situation evolves. But I think that if at every stage you have thoughtful reflection and intelligent conversation with those who love you, your family, people who mean something to you, and your physician about what's most important to you, then I think that you and your doctor will be able to come up with an approach to your treatment that makes sense for you. Thank you.
Thank you, Dr. Gillick. Our third speaker, before we then have the dialogue conversation that I've said is the real heart of the evening, and it's how we're going to make progress, is Dr. Angelo Volandes. You have, as you do for Dr. Gillick, in the materials, I think handouts when you came in, but also on the web, the official biography, abbreviated, of Dr. Volandes. I first met Dr. Volandes when he was a Harvard undergraduate philosophy major, and as an undergraduate, took the medical ethics course that I took at Harvard Medical School. Immediately resonated with him because I'd been a philosophy major before medical school, and shared with him a sense that philosophy can be important in helping us think, understand some things, but actually the real direct experience and engagement in the world is what really matters. And Dr. Volandes has really brought to the work that he's going to talk to you about both thinking about moral and other issues, but the practicalities of how to help concrete people in concrete ways. So Angelo, it's a thrill to have you with us, and look forward to hearing you.
It's great to be here. When asked, where do most Americans want to die? Home. In that most prestigious medical journal, Consumer Reports. That was a joke. Nearly 85% of Americans want to die at home, focused on comfort and surrounded by their loved ones. But what are the facts? Where do most Americans die today? Hospitals. Nearly 2/3 of Americans over the age of 65 are going to end up dying in a hospital or another healthcare facility. That misalignment between the type of medical care Americans want and the type of medical care they end up getting in our healthcare system today is what I consider the most urgent problem in American healthcare. Now, you've all been reading about it every other day on the front page of the New York Times, Boston Globe, LA Times. There's another story about end-of-life care. Unfortunately, it's often written through the prism of cost. And I ain't gonna lie to you, end-of-life care in America is extremely costly. But what I'm more concerned about is that a lot of the stuff that we doctors do at the end of life to you patients, and your people before your patients, is purely unwanted care. If you walk into my hospital and you end up getting something at the end of life that you never bargained for, it's unwanted care, and let's start calling it for what it is. It's a medical error. It's no different than a surgeon who is amputating on the wrong side of the body. It's no different than an ICU doctor not following some checklist. It's a medical error. Now, why are we in this state of affairs? Why are we the most developed healthcare system in the history of medicine? Why are we getting it so wrong? Well, I think the main reason is that most of us doctors, were never trained to have the conversation. Look, I finished 4 years of medical school, 3 years of residency, 3 fellowships in 4 years. In order to be called doctor, I had to show that I could perform 10 episodes of CPR, 5 central lines, 3 lumbar punctures, and 2 paracenteses to be called doctor. But never did a senior physician ever certify that I could actually talk to a patient. That's the reality. But you know, in today's visually literate society, sometimes words are not enough. Sometimes we need images, videos, to help all of us know what are the questions we need to ask ourselves, what are the questions we need to reflect on, and what are our medical options when it comes to care when we have a serious illness. So that's where we're going to go, but I thought I'd begin with a story. I want you to meet Professor Helen Thompson. Helen Thompson was one of this country's foremost literary critics on the poetry of Walt Whitman. By a show of hands, how many of you are familiar with the poetry of Walt Whitman? Great. Well, I was born and bred in Brooklyn, New York, where Whitman spent the first half of his life. So every other street corner had a Whitman elementary school, and all the pupils were forced to memorize the opening lines of Whitman's magnum opus, The Leaves of Grass. So Professor Thompson and I hit it off because we could both recite those lines. I celebrate myself and sing myself, and what I assume, you shall assume, for every atom belonging to me as good belongs to you. Now, you may be asking yourself why this doc is talking about Helen Thompson or the poetry of Walt Whitman. Well, what I haven't told you is that Helen Thompson was my patient just a few years ago. What I haven't told you is that Helen Thompson was an elderly female with widely metastatic cancer being admitted to my hospital. What I haven't told you is that Helen Thompson was dying. And so on that day that I admitted her to the hospital, I did my history, I did my physical, and then I got to that part in the H&P that all doctors get a little bit uncomfortable with, and that's when the words of Whitman metamorphosed into other words. Words like goals of care, CPR, comfort care. And so I looked at the professor and I said, Professor, you have seen scores of doctors before ever laying eyes on me. Oncologists, pulmonologists, primary care doctors. Surely someone has started the conversation with you. And she gave me that blank stare that so many of our patients give us. So what could I do? I started my own conversation with her. I said, Professor, what's a good day for you? Professor, I think we need to have a forest from the trees perspective. I think we need to know the risks and benefits of all these interventions, but I need to know where you are on your journey with this illness. And that's when she continued giving me that blank stare. So I naively asked her, Professor, would you mind taking a walk with me to the intensive care unit so I can actually show you some of these things? Of course, she obliged. We didn't walk to the ICU. I put her in a wheelchair, rolled her down to the intensive care unit. Got to show her a breathing machine, got to show her a patient on a breathing machine. And what the professor was able to do was to get a sense of the place, to hear the beeps and buzzes, see the colorful monitors, feel the rhythm of the intensive care unit. Now, as fate would have it, I obviously didn't plan on this, but there was a code blue in the ICU, and that's when I immediately whisked the professor out of the intensive care unit, but not before she caught a few glimpses of CPR. When we went back to the room, she looked at me, and she said, words, words, words. Angelo, I understood every single word that you said before. Goals of care, CPR, comfort care. I am, after all, a professor of English. But I had no idea that's what you were talking about. It doesn't look like that on television. And that's when it occurred to me at a relatively young professional age that so often in healthcare, we doctors try to have this conversation, but our patients are thinking about ER or Grey's Anatomy, where the miracle cure for your cancer is right around the corner, where everybody survives CPR, and where everybody looks like George Clooney on Event. The reality is very different. And so what I began to do was to take all my patients, all with a serious illness, on their own personal tour of our hospital. I even took their families. I would take families to the intensive care unit. I would take families and patients to the dialysis unit. And what every single person told me was that this was the most powerful and empowering experience that they had ever had, that they couldn't imagine making a decision about care at the end of life without my tour. Now, the nurses loved what I was doing. They saw the educational value. They're the smartest people in the hospital. But they quickly put an end to my tour business because they also knew I was breaking patient confidentiality. And so here's the conundrum that I was left with. How could I recreate this powerful experience to provide my patients and families with the questions they need to ask themselves, also with the options they need to know about? And that's when I came up with the idea of creating short films to better inform patients about what are the questions you need to ask, and what are your options for medical care when you have a serious illness. Now, it's not just me. It's a group of 100 of us from 10 academic medical centers around the country. We're based out of MGH. And what we try to do is, what are the tools that we can provide to you so that you can help us have the conversation? But you know, great ideas in medicine sometimes don't work out. The history of medicine is littered with ideas that in theory were great, but in practice either had no effect or worse, had a negative consequence. So what my research group does is actually study over time what happens when patients are empowered to know the questions they need to ask and their medical options. So I thought I would tell you about one of our studies. We are at Harvard Medical School, so we're going to be clinical researchers right now. What we did is we took 50 patients, all with advanced cancer, just with a few months left to live. And what we did is we randomized the group. We split the group into two groups. Half of the group had a conversation about what sort of medical care they wanted now that they had advanced cancer. The other half of the group had the same conversation, and then they saw a short video that told them, these are the questions you need to think about. Oh, and by the way, here are your medical options. Now, these are the three medical options that everybody across this country has: life-prolonging care, limited care, and comfort care. With the first option, life-prolonging care, it's really focusing on quantity of life, not quality of life. So that would mean you would want anything available in a modern-day hospital. With the middle category, limited care, it's focusing on actively how you're functioning. It means treating treatable things. So it usually means being hospitalized, but ICU, CPR, no thank you. And the third option, comfort care, here the focus is on quality of every day, not the quantity of every day. So those are the three options that all the patients had, but for the group that saw the video, they got to see visual images of each of those categories of care. Now, we have over 100 videos. They're all pretty short, less than 5 minutes, and they are vetted by experts, doctors, nurses, social workers, chaplains, patients, the #1 experts in healthcare, and patients' families. What we're trying to do is to provide you, people, with the questions that you need to know and your options. We're not trying to nudge people one way or another, pick this or pick that. We're trying to provide you with the information that you need in order to make an informed decision. So I'm going to show you one of our videos, which is on YouTube, and I'll give you the address at the end, so you got to wait until the end. But imagine how much better healthcare would be if all of us were empowered to make decisions like this. Talking about medical care at the end of life can sometimes be difficult, but it doesn't have to be a sad conversation. There's a common 3-step approach to do it well. The 3 steps are: start the process and have the conversation. Talk to your loved ones about your values and what's important to you. And then, talk to your healthcare team about your medical choices. Let's review each one of these steps so you can make sure you get the right care at the right time and on your own terms. Don't wait for your doctor to start the conversation. Start the discussion on your own with family and friends. Here are 4 questions that can help start the process. What kinds of things are most important to you? What concerns do you have about getting sick or needing medical care? If you were very sick, are there any specific medical treatments that might be too much for you? And finally, what are your spiritual, philosophical, religious, or cultural beliefs that would influence your medical decisions? Considering these questions is only the beginning. These reflections are not a one-time event, but a process that you should return to over time. After you've thought about your values and wishes, it's important to share your information with your loved ones. Holidays are a good time to start having these discussions with the people you would want to be around if you became very sick. Pick a calm and quiet place to talk. The talk doesn't have to have a certain structure. Let it just happen. And you don't need to establish everything with one conversation. After the conversation, I often tell my patients to use their cell phone or tablet to film themselves telling their loved ones what is most important in their lives regarding medical care. They can then send the video to them. And if you are ready, complete the appropriate legal paperwork. Now you're ready to complete the last step, talking with your healthcare team. Talking with your doctor is vital, since he or she will know your medical condition best and will be able to help translate your preferences into an actionable medical plan. There are 3 general approaches to medical care for people who are very sick. They are life-prolonging care, limited medical care, and comfort care. The first approach is life-prolonging care. With this option, the focus is to lengthen life. This includes all medical care that is available in the hospital, like CPR, breathing machines, and treatments in the ICU. For healthy people, CPR has a good chance of success and has improved over time. However, for people with an advanced illness, CPR's overall effectiveness is not high. It's important to ask your doctor what the chances are that CPR will work in someone like you. Sometimes, people decide to try life-prolonging interventions for a short period of time, and if the interventions are not successful, they move to the next option, limited medical care. With limited medical care, the focus is to take care of treatable problems. People who choose this approach want medical care that will help restore their health. My father received limited medical care. He had IV medications with careful monitoring. But he did not want any life-prolonging interventions like CPR and breathing machines. He chose to avoid these procedures even though he might have died without them. The third approach is comfort care. With comfort care, the main goal is to be comfortable. Treatments are only used if they help make people feel better and improve their quality of life. People who choose this approach are usually treated at home, in hospice, or sometimes in a nursing home. Talk to your doctor and your loved ones. If you let them know your choices, they can help make sure that you are at the center of and in control of your care. Are all of our doctors having conversations like that? You're all laughing. If I asked you, are all of your surgeons amputating on the correct side of the body? Not a single person would laugh if anybody said, no, they're not. But when we talk about end-of-life care and about your doctors being able to talk with you, we all giggle. No more. People need to be empowered. Videos can help all of us know what the questions are we need to ask and what are our options for medical care. Remember those 50 patients, all with advanced serious illness? What do you think they wanted in the arm that only had a verbal discussion? In yellow, we have life-prolonging care. In blue, limited care. In green, comfort care. Before I show you our results, just in your mind's eye, have the distribution of preferences. This is what we found. 26% wanted life-prolonging care in yellow, 52% in blue wanted limited care, and 22% in green wanted comfort care. Now ask yourselves, what do you think the group that had the conversation but also saw a video, what do you think they wanted? The overwhelming majority wanted comfort care, and I'm not even showing you all of our results. People were more certain, people had more knowledge, all those good things. If a picture speaks 1,000 words, videos speak hundreds of thousands of words. We've been doing this for over a decade, over 15 clinical trials. We see the same thing, over 2,000 subjects. When we talk to elderly people about decisions about advanced dementia, when they have a conversation, focus on the green, 64% want comfort care. But when you add a video and they actually see what's involved, very different picture, 86%. When we go to primary care practices and they have a conversation with their patients with a serious illness, what do we see? 72% in green want comfort care. But when patients know the questions and see the options, 91% want comfort care. When we go to nursing homes and have a conversation with residents at the nursing home, 57% in green want comfort care. But when our residents actually know the questions they need to ask and know their options, 80% want comfort care. We even went to our ICU, where I'm not having the conversation with the patient, but with the patient's loved one. When they have a conversation about CPR, 78% want CPR attempted. When they actually see what's involved, 41%. 15 clinical trials, 2,000 subjects, the same story over and over. Our group is trying to change healthcare in America, and we're trying to transform it. Today, there are 200 places, hospitals, nursing homes, doctors, healthcare systems across the country in nearly 25 states that are prioritizing having the conversation by empowering you, people, patients, and families to know what are the questions you need to ask and what are your medical options. Now, I could try to work with one patient at a time, one hospital at a time, or one healthcare system at a time, but I still wouldn't budge the needle when it comes to healthcare in America. What we've started to do is work with one entire state at a time. Our very first state is the Aloha State, where all the hospitals, all the nursing homes, all the physicians, all 1.4 million residents of the state of Hawaii are prioritizing having the conversation and using our videos to transform healthcare. But you know, a video of me talking about end-of-life care ain't gonna cut it in Hawaii. I don't look particularly Hawaiian if you haven't noticed. But what we decided to do was to refilm all of our videos, and we used the chair of medicine at the University of Hawaii, who looks a lot more Hawaiian than I do.
Decisions you might have to make in the future if you become very sick.
But you
I'll show
know,
you some
my research
examples.
group created an entire suite of Spanish videos, but there aren't many Latinos in Hawaii. So working with the local population and clinicians, we came up with an entire suite of Chinese, Mandarin, and Cantonese videos. But why stop there? We created our Filipino languages, Tagalog and Ilocano. And why stop there? We created all Asian languages, Korean, Japanese, Vietnamese. But when we looked at the inequities in our healthcare system, it really were the minority populations that were suffering the most. So we created the first ever Samoan and Marshallese or Chuckies video. If you're able to meet people where they're at, if you're able to provide them with the questions and their options that is respectful of their culture and language, what could possibly happen in American healthcare? Because at the end of the day, what we want is what you want. When Professor Thompson, or when any of our patients, when any of you, when you walk through those hospital doors, you have the right to expect not only the latest and greatest in terms of technology, but the right to expect that your physicians talk to you about the conversation. Thank you very much.
So I'd like to thank all of you for your attention, but also for our speakers to stay on time for our goal of having a full half hour for a conversation. I think Angela may still be collecting additional cards. There are obviously way too many for me to ask all the questions, but I'm going to lump them into some categories. Since the, since the fundamental central issue, as I said at the beginning and as we've heard from everybody, is all of you talking with the people you care about, you love, about your human goals. When I'm with a patient or family, for the first time I say, can I give you a homework assignment? They kind of laugh. I say, I'm not your teacher. I'll give you an A even if you don't do it. But I offer 2 questions said to think about, and I'll come back tomorrow. In whatever time there is ahead, and I don't know how much there is, we can talk. Number 1, what do you most hope for as a person in whatever time there is ahead? Honestly, most of us haven't thought about that. We're so busy today. And then the second, in whatever time there's ahead, what do you worry about? What do you not want to go through? If we understand those in human terms, then we can actually make medical plans that have the best chance of what you want in the time ahead happening and the least chance of things that you don't want. But it's easy to say have those conversations. I've got questions from a few people and would love Dr. Gillick, Dr. V'landys. One, asking for Dr. Gillick, but I'm going to read 3 or 4 and you'll get the gist. How can we encourage our elders to have the talk with their doctor and family when they are well and the mind is clear regarding end-of-life care? That's one question. Second question, who should start the conversation about end-of-life care? Family, doctors, nurses, PTs, social workers? When is the best time? How can a younger person have a conversation with an adult, with an older adult, a child with a parent, who doesn't want to talk about this? Right? And then, most directly, his stock answer to every question is, whatever. He doesn't even have a will. All right, so Dr. Gillick and then Dr. V'landys, thoughts, advice for people? Because truly we want you to leave here having some sense about how to start having these conversations. So, advice.
Well, I think, is this broadcasting to you? Okay. All right. I wasn't sure which of these various microphones I'm supposed to use. I think with respect to the last question first, the person who doesn't want to talk, people don't have to talk. And if they don't want to talk, that's not the end of the world. But you can point out what will happen if they don't and what the default will be. And just to explain that if we don't hear from you otherwise, in the American healthcare system, as Dr. V'landys described it, you will have a list of some of the things that they will have. So that's one way to get around that question. Another is to simply say that, to ask, why don't you want to talk about it? What are you afraid of? And the other, of course, is to punt and to have somebody else do it, which leads to the other question of, well, who should bring up the subject? It doesn't really matter, and I think it's different in different families and different situations. I think ideally we would have doctors all raising the issue. As you heard so eloquently, that doesn't always happen. I think that people need to be encouraged that they will be listened to if they do raise the issue. So there's no magic formula except to encourage, in whatever way you can, having a conversation.
I'll just add 2 comments. First comment is the number one inspiration to have this conversation is what Dr. Gillick said, which is namely, let me tell you what's going to happen if you don't have this conversation. And then there's quite a different tune. For the sons and daughters out there, because the truth is at the end of life, it's usually sons and daughters, friends, who are making these decisions. The best way to start this conversation is to say, hey, Mom, Dad, you know, I just read this newspaper story where Mom had advanced dementia, there were 9 kids, nobody really talked, and so all this bickering occurred amongst the family. I don't want that to happen to us. I love us too much. Let's have a conversation. The second question is about who should be having this conversation. There's nothing medical about this conversation. Talking about existential questions like life's final chapter, I didn't go to med school for that. I really didn't. I went to do things, but talking wasn't one of the top things that they taught us to do. So why aren't these conversations happening at church, synagogue, temple? You know, in Hawaii, we have the religious establishment start these conversations after church on Sunday. Why not? And the final thing is, let's leverage technology. Let's not treat a 21st century problem without the use of our technology. I tell my patients all the time, let's have a conversation. Let's watch a video. Let me Skype your daughter from California into this conversation. Then I'm going to use my iPhone or my tablet to record you. We're going to make a recording of what your wishes are. I'm going to email that short video to your loved ones, to your doctors, to your super specialists, and someday, there are some hospitals that already can do this, we're going to send that to your electronic medical record, where that's going to be uploaded into the EMR. And this way, when you are sick, and I'm the ER attending, and I see you at 3 in the morning and you're not able to talk with me, and I don't know who you are, I go to the electronic medical record, oh, medicines, surgical history, oh, wait a minute, they sent us a video. Let me check it out. I hear a voice, I see a face, I know what you want. And this time, when I'm calling the daughter in California, it's not, hey, daughter who hasn't seen mom in a year or two, what do you think mom wanted? It's, daughter, mom actually thought about this and left us a video. Let me send you a link to the video, and then let's talk about how we can honor and respect mom's wishes. What's possible?
So, thank you. Before watching time, before I move on to the opposite end, which is a number of questions about health insurance, the health system, what gets paid for, all of those things, just add a couple of things. The Conversation Project, which is, there's information about the link to that in the materials that you have for this, or you can just Google the Conversation Project, has a starter kit with guidelines about how to get started, and advises having the conversation where you live, work, and pray. It's a human conversation, and then the medical things. But one of the things that's emerged from the people who have actually tried this out and then it's actually worked is they increasingly are using the word to describe these conversations as gifts. What an amazing gift it is when your parents talk to you as kids. What an amazing gift it is when a husband talks to a wife. And when I'm in the hospital and people have had this conversation with their parents, I just reinforce, what a gift your mom gave you by talking about these things. And then, as they're feeling good, I say, and you might want to give that gift to your kids. And then sometimes humor helps. At our hospital for years. The few days before Thanksgiving, we have display tables out, time to talk turkey. But it's actually handouts. We say, just take these things, blame us at the hospital when you've got family around for Thanksgiving, and say, whoa, look at what this, they were handing out, time to talk turkey. You know, it actually would be a gift. Right? But again, we have to learn together. So health system questions. Why can't an end-of-life conversation become part of the dialogue with a GP or internist when you're healthy? Right? with health insurance, with insurance companies not allowing patients to stay in the hospital for more than 3 days, how do you justify keeping people in for palliative care? All of you stress the importance of talking with your doctor about what matters. How does that work in a medical system where I get about 6 minutes of time at one appointment? And does insurance make it prohibitive and difficult to actually get the kind of humane care you want? To say, a patient in the hospital whose family says choose the ICU, tens or hundreds of thousands of dollars will be paid for by Medicare. In our system, if they want to take mom at home and 2 hours a day from the health aide from hospice isn't enough, they can't do it, it's not paid for, it's too expensive. You guys are the ones, whether you're as taxpayers, voters, members of health plans, that need to insist that that change. But comments about 6-minute visits, how do you do this, what should people here take as lessons?
Go ahead.
6-minute visits. Get used to it. It's unfortunate. What you have to do is take back healthcare. You have to demand, we're going to talk about it. You walk in, let me be honest, I'm an inpatient doctor, a doctor who sees patients in the hospital, and when I walk in, I have an agenda. I have to find out what meds you're on. I have to find out about your surgical history. I have to find out why you're here. That's my agenda. Recently, a patient who did see one of the videos actually came back to me and said, hey, Angelo, take a seat because I want to ask you some questions. And that's when they're empowered. When you know the questions you need to ask, guess what? You're in control. The great thing about the conversation and using these videos, I think, is that it levels the playing field. Right now, if we have a conversation, I'm going to steer it because I hold all the cards. But if you flip the power and you know the questions, well, then you could start steering the conversation. That's the first thing. The second thing is, let's be honest with each other. For a lot of people in our society, some of these categories, some of these options simply are not realistic. In the Boston area, the Wall Street of healthcare, we are reimbursed $10,000 a day in the intensive care unit. But if I have a patient that wants comfort care at home, that hospice nurse, and it's usually a nurse, will only get paid about $150 for 1 or 2 hours, maybe twice a week. That is an injustice. The only way it's going to change is through your votes. We need to be able to compensate end-of-life care when you want to focus on comfort and being at home just the same way that we give tens of thousands of dollars for a few days in the ICU. What a wonderful society if my hospice nurse got that $10,000 to keep the patient where they want, to focus on what's important according to them, than to give all this money to intensive care unit care, where if you want it, God bless you, I'll do it. But most patients usually don't want it, but they don't have the option because they're not billionaires who can pay for 24/7 care at home. That's the reality, and it's only going to change if we all change it together.
And on that, whose money and whose health system is it? Right? We hear about, well, the payers, the third parties, the insurers, the people with the money, all of those. Where did they get the money? Every single penny in Medicare came from taxpayers. Every single penny in Blue Cross, insurers, whatever, came from workers out of their paycheck. Every single penny that ended up on health system came from you guys. If the money is not being spent the way you want from your health care dollar, it's not going to change until you insist.
No,
So-
just
yeah,
to
you're
say
right.
just 2 words on that. First of all, you don't have to address all possible issues at every single doctor's visit. I think it would come as a great relief to physicians to recognize that just as you don't have to deal with the blood pressure and the diabetes and the cholesterol and the arthritis and everything else in 1, 6, or even 15-minute visit, there is such a thing as a follow-up to do something else. So some of these things that really require more time need to be scheduled as a separate visit. And it's also an opportunity to say, I want to bring along my whoever, daughter, son, husband, to participate in that conversation, because when you're talking about what matters to you and how you're going to translate that into specific medical care, it is crucially important that not just that the doctor be involved, but that the person who would make decisions if you lose the capacity to decide for yourself is aware of the conversation and preferably participates in it. And the other thing I wanted to say with respect to talking about matters when you're well, it is certainly the case that a bad time to talk about it is when you can hardly breathe and you can hardly think. So we certainly want to have discussions about what matters to you, what your goals are, what treatments you'd like at some time other than in the midst of a crisis. My personal view is that I'm not sure how much has to be talked about if you're truly well. What you need to focus on if you're truly well is designating a person who would speak on your behalf if you're not able to. You're likely to change your goals, as I suggested, as you progress through life's journey. So a good time to talk is not exactly when you're well, nor is it when you're imminently dying or in the midst of crisis. The best time I would submit is when you've recently had a diagnosis of a new serious problem, or a problem that you've had for some time has gotten worse. And it's reasonable, I think, at that time to raise the issue of what do these new facts that you have told me, what do they mean for me?
Several of the questions are variations on the theme of the barrier to actually talking about this openly, even planning is, honestly, despite all the things we've said, the whole idea of death is terrifying. For each of us individually, when we're thinking about death, we're human beings. It's like we're wired, we're scared by that. So I have questions like a recent epiphany. As long as I am more afraid of death than I am of the healthcare system, I am at their mercy. And honestly, in the emergency department, there are other variants. There people are asking the same kind of, how does one ever accept the last phase of life? And aren't you all saying, well, this is about living, this is about what I want in the last phase of life, but come on. It's also about death, and as soon as that's on the table, nobody wants to talk about it. Thoughts?
Well, again, I'm not sure that I really think that it's all about death. It really is about what makes sense for you given your physical and mental reality. And I think while it may be particularly difficult for people in their 20s or 30s who are afflicted with some terrible disease, my personal experience is that a lot of people, when they are 75 or 85 or 95, not all of them, but a lot of them do understand that they are not immortal. And they also understand that a lot of the things that we do to them in medicine take a toll, and that those things will have repercussions. So we can talk about the kinds of the way that we want them to live their lives. They can talk about the way they want to live their lives. And I can then turn around and say, well, to me, what that means is that there's a lot of medical treatment that you want, for example, but certain things you probably don't want, because you've just told me that you want to be able to be independent and go for walks every day. So if that's what's really important to you, then I think that a prolonged stay in the intensive care unit would not fit with your goals.
Let's not sugarcoat the fact that death is ugly. Anybody who has seen death knows what the shortness of breath is like, knows what the pain is like. It is not a simple thing. But what I often tell my patients who all of a sudden become selfish, and I want them to be, is what I tell them is, I can do things to you that in the hospital, I'm going to bring your kids, and that will be the lasting image that they will see of you. Do you want the lasting image that they'll have forever to be with a tube down your throat? To be swollen? Is that the lasting image? What if we took this burden off of the children, that we actually had the conversation, and that we try to make the fact of our own mortality something which is the new normal? Look, we need to change as a culture. There's so many things we need to change as a culture. This is one of them. We need to talk about it. And for the person who said that they're more scared of death than they are of the healthcare system, I beg to differ. I'd like to take you on a tour of hospitals.
So then a question, aren't doctors supposed to talk to patients regarding end-of-life care and advance directives? Isn't there a Medicare requirement? This is actually very important for all of you who are Medicare age. You remember death panels? Right? I don't know how many remember what that was about. In the Affordable Care Act, in the bill, in the Senate, there was a line that said that if someone in Medicare, patient, once every 5 years, up to once every 5 years, wanted to talk to your doctor about life-sustaining treatment, was the phrase, then up to once every 5 years, that could actually count as a visit for Medicare, and your doctor could say, this is what justified the visit. Without that, the conversation has to get squeezed in between high blood pressure or arthritis or all those other things. And then Sarah Palin screamed death panels, which wasn't even there, and everybody ran away in terror. Fortunately, finally, in the last year and a half, that has now gone without any opposition through, and Medicare now has started to say this now can count as a visit. I think it's once every 5 years, but it's not frequently. So if you're Medicare age, other insurers are behind. Right? Other insurers are behind, but if you've got health insurance of whatever kind that doesn't cover the things that you think you need to do with your doctor's time, you ought to be, as people, as Blue Cross or whatever insuree, saying, this isn't the right kind of health insurance for me. Right? So some of us will support you. So for Dr. Gillick, little change of pace. Can you explain flying colors expression? Do you know what that means?
Well, I can tell you my usage. I don't know if there's some other reference here. When I said that the patient that I was describing got through the surgery with flying colors, what I meant was that everything went technically very smoothly. There were no complications. It proceeded exactly as planned. The complications I suggested came later.
And then Dr. Angelo, why is only the state of Hawaii having the conversation and not the rest of states?
Well,
And why is the conversation practice skills not taught at medical schools in all 50 states?
so the wonderful question. First things first, I did say it's the first state. There are quite a few others that are trying to replicate what we've done in Hawaii. But let me just speak about pedagogy. We're at Harvard Medical School. We not only deliver great care, we try to train the future leaders. We need to train the medical students to do this and to recognize that it's just as important as the neurosurgical technique that they're going to learn in residency. Having the conversation is probably one of the hardest procedures to do, even though we don't talk about it in those terms. In Hawaii, all the medical students, nursing students, School of Public Health students, residents, fellows, and young physicians all have iPads with our videos on them. This is how they're learning to have the conversation. It's becoming the new normal. So yes, we've come a long way. I graduated medical school, I think 15 years now. I had never heard of palliative care. I was never trained to have the conversation. Here at Harvard Medical School, we are one of the leading medical schools when it comes to training the medical students on how to have the conversation. And I'm hopeful that the time that these kids, and I look at them and I'm like, oh my gosh, you're kids, become the future physicians, things will change, culture will change. I'm worried about everybody who is experiencing this now, who has physicians who graduated more than 10 years ago who never had this.
Several of you asked questions related to euthanasia, assisted suicide, Hemlock Society, what if somebody has dementia, all of those things. So I want to at least say a few words about that, my own personal views, and then if Dr. Gillick or Dr. Valandis want to add something. My personal deep concern about, I'm in Massachusetts, but there are people all over the world looking at this. My personal deep concern about this issue, which was on the ballot in the state of Massachusetts in 2012, will be back on the ballot in 2018. You have to have 6 years. My personal deep concern is twofold. One, every patient that I've ever been asked to see who is asking, well, can't you give me something so that I can end my life? So far, every patient, when I spent time understanding what they worried about, what they might hope for, every patient with palliative care, hospice care, family support has basically said, well, never mind, if it can be like that, I'm okay. I thought about 2 years ago I'd met my first, because some of the doctors I most admire, other places say, well, you just haven't seen enough. You'll meet somebody where all the things you do aren't enough. I thought I'd met my first. Patient with advanced pancreatic cancer, no more effective treatments, just wanted this over. If only he lived in Oregon. And talking to him, it's illegal in Massachusetts. I said, well, if you really don't want any longer time, then if you just decide not to eat or drink, and it's really the fluids, if you decide not to take in more fluids, people do not live more than 2 weeks with 0 fluids. And your mouth can be kept moist, and hospice nurses can help with those kinds of things. I mean, you can do that anywhere. And actually, that 2 weeks may sound like a long time, but if you were in Oregon, there's a 2-week waiting period. Right? So the next 2 days, I go up there, and he's in the hospital. He's just like, I'm done, Dr. Farrar. I'm just sorry it takes this long. But so I told people, I think I've just met my first patient for whom this is the right thing. The next day, I go up there, and he's drinking this big jug of ice water. And I said, like, what are you doing? And he says, I've been thinking about what we've been talking about, and my grandchildren, they live on the West Coast, and I think I would like to see them one more time, and it'll be a couple weeks. I want to be in good shape when they visit. Right? So my concern is that in the absence of help with palliative care, hospice care, other things that might make this last phase worth having to people, that legalizing or having the choice of assisted suicide worries me. Particularly because in Oregon, where it's been legal for 15 years, less than 3 per 1,000 people actually choose it. 99.7% of all the people in Oregon where it's legal, they choose other things. I'm most worried about the 99.7% in Massachusetts and other places who do not have the time with their doctor to plan these things and all of that. But I'll also say, having said that, if I knew everybody had the gold standard core choices, I wouldn't have a problem for the small number of people for whom this is another choice that they would want to have. That's my personal view. I don't know if you'd like to add anything. We're down to the last minute.
So I'll just add something quickly. These are challenging questions about euthanasia, and they deserve to be aired. But there are 3 million deaths in this country every year. This issue affects a sliver of a percentage. And I'm okay with talking about it, but I'm more concerned that the 99.99% of deaths where palliative care and hospice services are not an option, their voices are never heard in the press whenever we talk about this issue. And knowing that minority populations, African Americans and Latinos, do not have access to adequate palliative and hospice services, I find that to be much more concerning before we start talking about issues like this.
So I'm going to leave us with 2 thoughts, because it looks like time is just about up. Am I right? Yes. I've done a lot of work in Africa, the Albert Schweitzer Hospital there, and a saying I learned from Africans said, be very careful when you point your finger at someone, because your hand is much smarter than you are. 3 of your 4 fingers are pointing where you should actually be worrying about things. So I'm grateful to Dr. Valandis, Dr. Gillick, and others, grateful for the questions, but actually, The value of this evening will depend on what each of you does when you leave here, talks about with other people. And then I'll close with a quote from Albert Schweitzer that was the epigraph on the state expert panel report that was mentioned that I had shared. Dr. Schweitzer wrote, "Something deep and sanctifying takes place when people who belong to each other share the thought that every day, each coming hour, may separate them. Something deep and sanctifying takes place. In this awareness, we always find that the initial anxiety gives way to another deeper question. There is initial anxiety. We might lose each other. Gives way to another deeper question. Have we given each other everything we could? Have we been everything we might have been to one another? Thinking about death in this way," wrote Dr. Schweitzer, "produces true love for life." So thank you all for joining us. Carry on.